Hello, I am Joanne Thio, PGY2 at Kirkakorium School of Medicine at UNLV Department of Pediatrics. On behalf of Patricia, Cachila, and Dr. Waldo Feng, I would like to share a case report on renal failure as a consequence of dysfunctional voiding. Voiding dysfunction is a common complaint seen in the outpatient pediatric setting. Abdominal pain, enuresis, daytime incontinence, recurrent urinary tract infections, and constipation are common complaints often associated with dysfunctional voiding. The International Children's Continence Society defines dysfunctional voiding as dysfunction during voiding and is the child who habitually contracts the urethral sphincter during voiding. It is considered a lower urinary tract malfunction and consists of a spectrum of presentation and severity. Though only a small number of patients present with severe dysfunctional voiding, delayed diagnosis and treatment can have serious consequences. Here, we present a case of an 11-year-old male who developed renal failure as a result of severe dysfunctional voiding. Our patient is an 11-year-old male with no significant past medical history who presented with approximately 9-month history of intermittent abdominal pain, nausea, and vomiting. Initial workup consisted of a renal bladder ultrasound that showed mild bilateral hydronephrosis, bladder pre-void volume of 520 ml, and a large post-void volume residual of 181 ml. Of note, the patient's estimated normal bladder capacity was 390 ml for his age and a normal post-void residual of 0 ml. After initial workup, he continued to have abdominal pain, nausea, vomiting, with new complaints of anorexia, low energy, 10-pound weight loss, and enuresis. Further workup with labs and imagings were done. Lab work was notable for an elevated BUN of 57 and elevated creatinine of 5.58. Renal bladder ultrasound at that time showed worsening severe bilateral hydronephrosis with severe grade 4 on the left and grade 3 on the right, with bladder volume of 354 ml and post-void residual of 134 ml. Given these findings, the patient was directed to the hospital for further workup. He presented to the hospital in renal failure with lab work indicating stage 4 renal disease. Renal bladder ultrasound showed severe bilateral hydronephrosis with increased bladder volume and post-void residual. An indwelling Foley catheter was inserted for bladder decompression, and after 48 hours, repeat ultrasound showed continued severe bilateral hydronephrosis with incomplete bladder decompression despite appropriately placed Foley catheter. Bilateral nephrostomy tubes were placed because of persistent bilateral hydronephrosis. However, subsequent imaging demonstrated inadequate bladder drainage and renal decompression. Indwelling double J urethral stents and a larger suprapubic catheter were then intraoperatively placed because of the incomplete drainage of his urinary tract. Subsequently, he had substantial improvement of his renal function with improving creatinine and eGFR. Follow-up renal bladder ultrasound showed complete resolution of hydronephrosis in his right kidney and decompression of his bladder, while the left kidney showed significantly improved hydronephrosis. He had significant improvement of his renal function with the continued decompression from the bilateral urethral stents and suprapubic catheter. However, full return of renal function did not occur by the time of discharge. It was determined that the patient's renal failure was a result of severe dysfunctional voiding. Hinman bladder, or non-neurogenic neurogenic bladder, represents one of the most severe forms of dysfunctional voiding and can have severe consequences. Thus, timely recognition and treatment is critical. Many children present with the typical symptoms of dysfunctional voiding. However, a small portion will present with vague, non-specific complaints that require further workup, including lab work and imaging. We want to bring attention to the renal bladder ultrasound as there are sonographic findings that should raise suspicion for underlying dysfunctional voiding. Increased bladder thickness, larger than expected bladder capacity, and or large post-void volume are concerning findings and should raise suspicion for underlying severe dysfunctional voiding. Treatment for dysfunctional voiding is typically behavior modifications and bladder retraining. Occasionally, more invasive methods for treatments are needed. Thank you for your time and attention.